And we wonder why people complain about post-operative pain treatment. It's not perfect. And then we add in the American culture on the back end of this, which is I want it now. So when we look at this, it's not just about identifying and understanding the fact that addiction is a chronic neurobiological disorder that has explanations for the behaviors that we see that frustrate us. But it's also that we are doing everything possible to continue to make it worse for all of those people that have it. I mean, how many stories do we have to hear of someone who had been diagnosed with addiction, who goes to the hospital, maybe even told 2 or 3 people that they have addiction, still ended up with that prescription to go out the door, had decision fatigue. By the end of the day, they actually fill it. They said, no, I'm going to take it back to my doc. They fold it up, they put it in their purse, have no initial intention of filling it. And then decision fatigue, I'm just going to fill it, I'm just going to take one, done. And then it's either an overdose or we're off to the races. So this requires a pretty consistent approach to how we're going to, 1, evaluate these patients, and 2, what it is that we're going to need to do in order to keep those things from happening. So this, I hope, has set the stage a little bit for why I am going to propose we do the next few things, right? And this is not based on my opinion. Opinions are pretty useless to me. Expert opinion is even more useless because we're blinded by the thought that we know everything on this. And so this is why every guideline that we write or everything should always have input from those that don't do exactly what we do. So like the guidelines that I wrote for the state of Michigan were reviewed, yes, by doctors, but also reviewed by social workers and patients and administrators before we put that out, to make sure that it made sense, that it was clear, that I wasn't off on some random pathway. Despite having loads of references and all of those things with it, you can still be misguided in the approach to some of these things. So when we talked about dopamine, and we said that low dopamine creates this behavior, and we know that like in depression, we have low serotonin, and we do what? Give them a medication that raises serotonin called a selective serotonin reuptake inhibitor. Right? Makes sense? Serotonin goes up, DNA changes the proteins that it makes a little bit. After a period of 4 to 6 weeks, we start to see changes in affect. People start to feel better. Now, where we go wrong is we're just happy with that, and we don't realize that the data shows that you should be on that for no more than 6 to 9 months before, and you should be doing aggressive therapy during that time. And then after 9 months of not meeting criteria for major depressive disorder anymore, you should be weaned off to see if you can maintain that level without being on the medication. But instead, in American medicine, we just keep you on that SSRI for eternity. But in addiction, we have the same basic problem, except with dopamine. So we have low dopamine. What do you want to do? Want to raise dopamine. So we tried that. We tried to raise dopamine by just giving dopamine, because we give Sinemet or L-Dopa for Parkinson's disease, and it works in another part of the brain to turn the shaking into steadiness and the Parkinson's shuffle into a normal walk. And we have access to that part. One of the problems is that as we start to look at this, the part of the brain responsible for reward is one of the oldest parts of the brain. It is very protected from outside influence. And so that's why when we gave just dopamine, in order to get enough dopamine in there to change what that felt like or looked like, we actually started to cause a ton of side effects for patients. And they would have movement disorders and speech disorders and hyperthermia, like all these really weird things would start happening. So we couldn't just give them dopamine. So we looked at drugs that raised dopamine secondarily, and one of those was like bupropion or Wellbutrin, because that's one of the things that it does is raises central dopamine. But it raises central dopamine by getting the body to release more dopamine, and if you're not making it or producing it, then you're not going to be able to squeeze more blood out of that turnip, right? So it just didn't work as well. So what we had to do was figure out how we can artificially kickstart the brain into making it again to release it appropriately. And what we found for the first time, and we didn't know this is what it was doing when we first found it back in the 80s, back with, I guess, the big hair and the shoulder pads, right? We talked about. Back in the 80s was what medication? I like the sound effects. That's right. Methadone. That is awesome. So as we start to look through this, we now have methadone, right? We started this back in the 80s for the heroin problem in New York, and they actually developed the first opioid treatment program, and they started it early in the 70s, actually, late 60s, for a very small cohort of patients. But what they found is that by giving patients this medication, that it significantly decreased their use of heroin. Therefore, at that point, decreasing the risk of infections, but then later turned into specific infections of HIV, hepatitis C, and things that we know. So let's say worst case scenario, and then we'll get into the metaphysics of this. So if we just talk about, I'm going to give you methadone, and if I give you methadone and I do nothing else, then you're going to be at a lower risk of getting HIV, you're going to be at lower risk for getting hepatitis C, you're going to be at lower risk for overdose, you're going to be at lower risk for heart valve infection and admission to the hospital, and you're less likely to go to jail. Those are all things that a bad methadone clinic do. I mean, so even when it's not done properly. But methadone is really interesting because it is the only drug that when I mention it, people have an emotional reaction to it. Even God, apparently. So when I mention methadone, there are people that are like, oh, you got like the eye roll, and they're like, oh, methadone. But you don't see cardiologists freaking out about calcium channel blockers. There's not like a faction of heart doctors that are like, I'm never writing a calcium channel blocker. I hate those meds. They just don't do that. It's a little weird that we have such an emotional reaction to a medication that even if used poorly has those changes in outcome. Because if that person was our family member and we know that by getting it they're going to have a decrease in HIV, a decrease in hepatitis C, a decrease in the risk of death, a decrease in going to jail, a decrease in heart valve infections and all, we would just be like, thank God, that's amazing. That's great. But then when you add the word methadone to it, then everybody's like, well, no, not that one. I'm not going to do it that one. So we just need to pull back a little bit and start to look at why we maybe have that. And the biggest thing, and I've asked hundreds of people this question, and it's been basically the same answer in one fashion or another, and it's just, well, aren't we just replacing one addiction for another? That's what I hear every single time. And the answer is a question. How do we define addiction? By the presence of a drug in a urine? Or by behavior? We define addiction based on behavior. So if their behavior, meaning they're not out seeking that drug in peril to themselves, they're not committing crimes to find the drug, they haven't destroyed their interpersonal relationships with other people in order to find the drug, if they're not committing crimes or they're not committing emotional fouls on everybody around them all the time, that means they don't meet criteria for addiction anymore, and they would be considered in remission. So if that's the case, and we put them on this medication, and they no longer meet criteria for addiction, we're not actually just replacing one addiction for another. We're just taking the medication that caused all of these horrible behaviors to happen and replacing it with one that looks alike, but eliminates all those behaviors and all of those outcomes. So we have to start wrapping our heads around the fact that we need to not make emotional decisions about the treatment pathways. We need to understand that there is data, science, and math for each of these. And whether that be for methadone, or buprenorphine, or for Vivitrol, naltrexone, or an alcohol use disorder, we have naltrexone, the injectable naltrexone as well. We also have Camprosate, we have Antabuse, we have, for that one we have a few now, gabapentin, topiramate, and baclofen. Those are meds that have shown real possibilities in that. We have a medication that helps decrease marijuana use by 60%. Anybody know that? Crazy, right? We're a medical marijuana state. We're like, everybody's like, dude, I totally have a medical problem. I need to smoke weed for that. And there's like one or two out there that I know are getting angry every time I poke at that. So save those questions. I love those questions. And but when we look at this, we start to look at exactly what it is that we have. And I'm not going to tell you until the second half, so you're going to have to stay for which medication that is for marijuana. But we have these medications, and we don't get angry at the type 2 diabetic because they require insulin because they consistently eat ice cream and Krispy Kreme donuts. We just don't. So we need to stop having an emotional reaction to the utilization of medications that significantly decrease risk of death, morbidity, mortality, infections, life crisis, all of these things, and focus on how we best utilize them rather than how we malign them. So this group of patients, I said, right, if we got them and we detox them and we decide that ultimately what we have to do with them is put them in 12-step, we have an 8% effective rate, right? So 92% of people at 1 year still meet criteria for an opioid use disorder. What do you think it is if I put them on buprenorphine and do evidence-based cognitive behavioral therapy? Well, I'll just tell you, 65%. What about methadone given in an opioid treatment program in a methadone clinic? 72 to 75% of people who start on day one no longer meet criteria for an addictive disorder at day 365. So then the next question comes up, right? The next question is, do they have to be on it forever? It comes back to how I described what happens to the brain. There are some that we just decrease the release of dopamine, right? And then there are some that we actually decrease the production of dopamine, some that shrink the nerve, and then there are some that actually kill off the nerve. If you've killed off the nerve or shrink it to the point where it's never going to make enough dopamine, those are patients who may need this forever. And again, in any other chronic disease, we don't care. We start somebody on an aspirin when they're 50 because they have a high risk of a heart attack, they just keep taking it till they die. We don't fix many things in medicine, we only control them. So we shouldn't be thinking that somehow we have to fix this chronic disease that messes with more parts in the brain than almost any other disease. So controlling the disease to the point where the behaviors are acceptable, that the person can now be productive in society, can go back to school and learn, can go and get a job. That's what we should be focusing on, is how do we use things like an opioid treatment program or a methadone clinic and get them better? How do we integrate buprenorphine into primary care practice and into opioid treatment programs and get them better? How do we get people to not malign them for needing a medication? How do we change the stigma of addiction so that it is just a chronic disease? How do we get the criminal justice system to work with us and understand that they're doing the same thing we are? And if we work together and let each other do their jobs that they're trained in and trust that they're going to do it with the same information, that's when we're going to actually start to be able to change long-term outcomes of communities and not just the individuals. But if you're a person who was 19 and you have an opioid use disorder because you stole Percocet from your parents' medicine cabinet that your dad got from a knee replacement, 3 years ago, but he's like, just in case I break my femur in the backyard, I should keep this. And I'm not immune to that, right? I had kids, I cleaned out my med cabinet. I had crap from forever ago. I had some Valium in there from when I had hurt my back one time, and I had leftover meds from an ankle surgery. I mean, I had all kinds of stuff when I cleaned out mine. But I cleaned it out. That's the difference. And when we look at this, what is that 19-year-old going to do when they are in the wrong place at the wrong time? So here's what happens. You have drug paraphernalia on you. You're in the wrong place. Cop shows up. Freak out. Run. That's an instinct. Especially when you got stuff going on. And then, when they get you, your instinct is to kind of fight back, especially when you're not using logic and you're kind of in this fight or flight mode without the pros, cons. Like if I get pulled over by a police officer, I know exactly, my light's on in the car, my window's down, my hands are on the steering wheel, and yes, sir, yes, ma'am, I mean, that's appropriate interaction with law enforcement so that they can feel safe, they can instruct us on what has happened, and then we can move from there. And either I broke the law because I was speeding again, or I didn't. But either way, there is a hierarchical of who's in charge in that moment that we accept as a society for order. The problem is that when you've lost your capability of logic, that acceptance of hierarchical order doesn't exist in that person. And so in that scenario, that person has a chance of 3 felony convictions for possession, for evading, and for resisting. So the magic number of 3 is you're done. At that point, you no longer have the capability to live a life in America. If you have 3 felonies, now here's the funny thing, and it's funny in a horrible way, but so probably the wrong word altogether. So here's an interesting piece, is that's also going to be considered a violent felony because it was resisting. In many of the ways that they look at felonies, that's considered a significant violent felony, so that would still be listed as someone who's not on the abatement pathway, like how we get them off, like the ones that were just adjudicated by the administration where they let people who just had drugs on them and were more for the disease. That person can't get a job. They can't get educational funding. They can't vote. They can't join law enforcement. They can't try to go back and do right. They can't join the military. They're done. They're done. So at that point, we've now taken that 19-year-old who got some Percocet from his parents' cabinet, and we've turned them into a lifetime criminal. Because how are they going to survive? Because if they're a young man in America, you don't get the benefit of the doubt for social services and stabilization in most places. In fact, only recently did 26 states, or actually now 27 states, say, I'll give you health insurance. There's still a large number of 23 states that don't have any even health insurance available if you're a male, and the only way that you get health insurance in those states is if you're pregnant. Boy, there's an incentive package. All you got to do is get preggers, and then I'll give you health insurance. Somehow that doesn't comport with what we're trying to maybe do, right? So these are the basic ideas that have happened, and it's not just, hey, they have drug addiction, we have medication, we should treat it. These are complicated problems. These are problems that require complicated solutions, but the interesting thing is we have solutions for that, right? So how do we fix that one problem? Well, you have certain confines when you adjudicate a case within this. It's not like you can just let everybody go. But at the same time, there is a felony abatement pathway for a certain subset of people, so that if they get this, you can plead them down if they follow through on certain pathways for treatment and outcomes, and you can plead them down onto parole for an extended period of time. Parole officers hate it when I say that because they're like, come on, man, I'm already busy. But at the same time, there are ways to do this within the adjudication process where we can take a patient, just like I have for the doctor, and I have a doctor who I own for 3 to 5 years. If they're assigned to me and they want to keep their license, they got to show up. They got to pee in a cup when I tell them. And they have to follow through on the meetings, and they got to do that. Well, if you don't have a medical license to hold over somebody who's 19 years old, you can definitely hold that other stuff over and use that as that negative contingency pathway that rapidly turns into a positive contingency pathway, which is you get rewarded for good behavior. Our justice system was founded on the possibility that you could actually commit a crime, recognize that that was a crime, and then pay for that crime, and then be done paying for that crime. However, the way that we have things set up with jobs, credit scores, and all of these things, you pay for that crime forever, no matter what happens. And so we have to come up with a way that we don't criminalize a disease, and then we have to come up with a way that we recognize it early, and then when we do recognize it, that we use evidence-based treatment that is 65 to 70% effective to make it better. Is there anyone that disagrees with that? Now's your time. Good, because this has been through a lot of saying stupid crap for a long time, right? Because you think that this is right or you think that this is not, but when you sit down and listen to the people around you and what they do and the problems that they have with the areas that they have to work on, those are the pieces that become difficult. So what I want to do now is, every session, what I want to do, because I can't stand up and give a talk about Cass County. I don't live here, right? I didn't grow up here. I don't have friends here. I actually do have friends here, but I'm not here all the time. And now I'm like some dude from Jersey, which is always going to be like hard to be like some random dude from Jersey. So I want to actually take questions now and in the second piece so that I can help to answer, or maybe help to bridge gaps for things that could be very specifically helpful for Cass County, or areas that maybe I wasn't as clear that I needed to be. So what we will do is you will ask a question, I will repeat the question, and then that way we can go. So who's gonna go first? Oh, we do have a couple of mics.
And so if you're in the middle, I'll bring this. There's green. I'm assuming that's
Hey, look, it's pouring down rain outside, so we're stuck here. So let's
across the campus.
yeah. Is that a hand?
Nope.
Sold to the lady in the front. Yes, sir.
I just wanted to say, when you're talking about certain behaviors go along with addiction, ever since the first of the Pirates of the Caribbean movie, when in that story that goes on in the jail, and one character says to the pirate, "You cheated," and he says, "Pirate? I've been waiting for one of my addiction patients to say, when I make some reference to their relapse, something they've done, I've been waiting for them to say, addict." And they haven't, but I keep waiting for that because so much of it is logical and should be kind of anticipated by it.
Well, this is a really good point. So the point is talking about, self-identification that, duh, my blood sugar is going to be high, I have diabetes. Or, sorry, duh, I'm going to yell at you sometimes because I have addiction and I haven't quite gotten it fixed yet. I'm going to freak out in the lobby. I'm going to do these things. And so what happens in these points is really important. So if you think about a standard primary care practice, you go in, they got the ubiquitous fish tank. It's got like 2 little betas swimming around in, or one, because one's half eaten because they forgot that you can only put one. And, but they got that, and they have the Scholastic magazine, and then some like People magazine, whatever. It's the same thing, right? And it's supposed to be kind of quiet. You wait, you're irritated that it's 30 minutes late, and then you go back and talk to your doctor for 7 seconds, and then you leave. We've just kind of adjusted to that being it. But when you go as another patient, and all of a sudden somebody's melting down in the lobby, to the person at the front because they don't know why they can't pick up their prescription for their refills of Percocet, and they're having that meltdown, that starts to make everybody else uncomfortable. And it's not just the people out front, but it's the people in the back. Now, if the people in the back are trained in how to deal with that and expect that behavior is just a natural behavior in a patient, again, with either chronic pain on opioids or addiction, because the overlap in those behaviors can look a lot alike, then what you're going to do is be able to come up with an intervention plan. And that intervention plan is not you seeing them that day and sending them a letter 3 days later that's saying they're fired. It's actually having someone bring them back, putting them in a room, and having a conversation with them about that, and giving them immediate behavior modification feedback. I mean, I don't wait for 3 days to yell at my kid when they jump in the middle of the road, right? Get out of that road. I'm from Texas, so that's okay. And it's not, it's just, so those are different. But when we do this, I mean, you have to do that immediate feedback, and that actually is a part of therapy. So think about this for a minute. If the average age of onset of this disease, meaning when they start using a substance consistently, is 13, 12 to 15 years old, how emotionally stable is someone at 13? 15, even worse, right? Because now they're sure they're right, but they're still emotionally unstable. So the rule of thumb to use with patients who have addiction is to ask them, how old were you when you started using your first substance on a regular basis? And it could be nicotine or whatever, their first mind-altering substance on a regular basis. That is their emotional age. I don't care if they're 50 when they're sitting in your office. Their emotional age is when they started using that substance, because that became their coping tool. Every time that they had a hard conversation, smoking a cigarette, or taking a pill, or taking a drink, or whatever, smoking a weed, whatever it was, that became their coping mechanism. And so because of that, they did not create all of those fun little connections that we need to cope later in life. They didn't just have to suffer through the breakup, right? And wail on the floor like the world was ending, you know? Or when you don't get the car that you wanted when you turn 16 because nobody's going to buy you a Ferrari when you're 16 and you live in a one-bedroom apartment. So, yeah, but you have like those freak out moments and you do it. You learn how to deal with those. We work through those. When you don't win an award, when you don't get a job, you don't get into a certain college, those are as or more important than the times that you do for being able to deal with adversity long term. And so when we take that away, and every time that they have something stressful happen, the substance is what gets utilized rather than coping strategy development, then we get what we get. So so now you have a 13-year-old and no dopamine. And it's just like chaos all the time. And they feel more comfortable in the chaos because now that's kind of what they grow. What do we call that person who likes to live in chaos? Borderline personality disorder, all day long. My patients are misdiagnosed with borderline personality disorder all the time, when it's really just a poorly treated or untreated addiction. And when you stabilize the addiction and deal with some of the underlying trauma, that goes away. I mean, the vast majority of personality disorders are all about childhood. They're all about early life trauma, neglect, abandonment. I mean, that's pretty much that's why they're so hard to treat. There's no medicine for a lifetime of something bad happening to you. And so these are the realities of these, and it takes focused, consistent behavioral therapies to get these back, which is why the behavior associated with addiction can be mitigated a little bit and sometimes quite profoundly early with just a medication. But if all you do is give them methadone or all you do is give them buprenorphine, that will wear off. And those behaviors will start to come back. Because they're, at that point, probably still going to be using that medication for coping. And when that happens, that's a problem.
The chaos and drama, is that a way to stimulate dopamine production? Is that like...
That's a great question. Is there more? Because
No, I have a 14-year-old. So.
Yeah, no, fair enough. Yeah. So is the chaos, the question is the chaos and all of that drama that goes along with that a dopamine stimulator? Indirectly, because what is a dopamine stimulator is attention. And so the attention that is received for that behavior, whether positive or negative, is the dopamine thing. So when we talked about good job, it's the same thing as go sit in a chair. You're in a timeout. That's attention. It's negative attention, but it's still focused on them. So generally, acting out or any of that, if you look at attachment theory and the way that those things go, from a male to male, so if your 14-year-old is a boy, then there's a conflict tension from that. If your 14-year-old is a girl, that conflict tension is gone. That's moved over more to the female role. And what you have to deal with is actually the appropriate amount of attention on the right things. And so if there's a lot of negative acting out specifically toward the male figure from a female figure, and it depends on also how they sexually identify, but I mean, if we just think kind of standard, when we do that, then what you're going to find is that they're going to be acting out because they just want more positive attention. And it could be on anything. So you just start, you don't reward them for stupid crap, so it's not like everybody's a winner, because you know what, in the world they're not. You have to teach them how to lose to actually strengthen some of these things up. But when they do something positive or they do that extra thing, even little bitty, they get that, hey man, you finally put one of your toys up. I know the rest of the room is a complete freaking catastrophe, but good job for like one robot somehow getting back in the box. That's great. Yes?
I'm an inpatient nurse. The one that looks at your allergy list and decides that you're a drug seeker.
Yeah?
At any rate.
Just don't use air quotes in the hallway. This is a good one.
Well, what I see at where I work is a lot of, not necessarily compassion, but let's just say I've dried out hundreds of drunks over the last many years. If I get someone who's addicted to narcotics, hostility. We make every effort to withhold whatever, or the physician will, not, what is the appropriate way to handle a narcotic addicted person?
Yeah. right? So that's a great question, because if a patient shows up to the hospital and gets admitted for whatever reason, infection, trauma, you know, the usual things that happen for patients with addiction that we forget to screen for addiction when they come in for those things, but they show up for their pancreatitis again, or they show up for a recurrent exacerbation of their chronic abdominal pain with normal labs and normal 50 CAT scans. Eventually they'll have cancer, but that's on us. And it's really just constipation secondary to opioid use, but that they want the opioid for that, and if you don't give it to me, then you don't care, and I want to talk to the CEO of the hospital, and yeah, I have been there, right? Because I'm the one who got called whenever everything else had, quote, failed. And what I found is that we had just not given them a good option. We have just told them what we're not going to do. I mean, that's all we do. We're like, I'm not going to give you narcotics. And that's the conversation. It's not a conversation of, wow, I'm really worried that we've caused a lot of harm to you in doing this in the past, and the conversation extending into, you know, I think it's constipation. You may completely disagree with me, and I get that, and you know your body better than I do, but I've spent my entire life learning about ways in which we can manipulate the body to get better. So I need to know everything about your body so that I can help you decide what the best way is. And all I do know is that you've been here all these times. Your behavior is such that you're so emotionally connected to these medications that we have to do something different. It's just not working. And they'll feign, it works when you give me the right dose. And your answer is, actually, it doesn't, because if you look here, we gave you all these doses, and it was still the same thing like 40 minutes later. So it's not that, and I think, unfortunately, we're covering up a lot of stuff we have to work on. But if you don't have the next step, which is, you know what we can do, is we can transition you off of this medication onto a buprenorphine, or we can get you referred to a methadone clinic, and you do an actual screen for addiction, because if you do an actual screen and you do the DSM-5, it's hard for them to argue when they meet the criteria. Like when I sit down with a patient and they have chronic pain, and that's why they came to see me. They were referred to me because they're in the ER all the time, because nobody can treat their pain, and it's all bogus, and they're not one of those people, and they show up. I don't tell them they're an addict. I say, well, you got chronic pain. All right, from what and how'd it go? I mean, not in this tone, because that would be horrible, right? But the empathetic version of that, very dismissive tone. But so fine. So you have chronic pain, and when did it start, and what have you done? And they'll be like, well, the only thing that helps my chronic pain are these medications. And I was like, well, show me where they've helped. And they can't. They just can't. Show me a time in which you were on the right dose of medications, and they do. And even so, I mean, there'll be times when they're a new patient that I may know in 7 seconds that they have addiction, but they don't. And so when I start talking about this, they may flip the thing over, what, do you call me an addict? And I'd be like, no, but boy, you sound worried about that. That sounds like something we should talk about. I mean, it's practice. It's all motivational interviewing. I mean, all of this is motivational interviewing. So how many people in here are familiar with motivational interviewing? Right. How many people in here have read 3 books and watched at least 10 YouTube videos on motivational interviewing? Everybody should, if you work with patients, that's the minimum requirement of understanding motivational interviewing, because motivational interviewing is not Tony Robbins, right? It's not like, look here, we can have this for 45. You too can also be awesome. You know, it's not just that. You know, it's not Chris Farley, like, you live down by the river. You know, it's not that. It is science. And it is math. I mean, there are specific techniques within motivational interviewing that you can redirect and rotate to, that you can piggyback off of, that you can use their response to help spin it around. Like the Columbo is one of my favorites, where basically somebody's like, well, you're just not trying to help me get better, and I just need to do this, and, you know, nothing's working for me. And I'm like, well, on this side you're saying, you know, you want to go back to school, but man, you haven't filled out anything. You haven't even identified schools. So I mean, maybe I have work to do, but holy cow, I mean, there's really a disparity between what you're saying you want and what you're doing to get it. And there's very specific techniques for this. And if you understand that the behavior of a patient with addiction is because they have addiction, then that takes away all that emotional stuff. Like, it's just fun now. Honestly, all I see are those patients that ruin your day. That's it. For a living, I have decided to filter for those patients who everybody else would pay other people money to see. And it's great, because I understand it. You get it. And once you just get that behavior is a symptom and not a frustration, it just makes it easy. You know, if they're in jail and they got picked up and they're acting like a 4-year-old, you know? You know, they probably emotionally stopped really growing around 4 because they got their ass kicked from 4 to 12 until they started using dope, and then at that point they covered it up. Sometimes they do that. Sometimes they act like a 4-year-old. Now I just like, that's pretty good. That's like a really good 4-year-old. I mean, that's amazing. Just call it out and move on. Because they'll be like, what are you talking about? I'm like, that's the problem. This is what gets you in trouble. How do we fix that? It's not about the pain or the whatever, it's that. Because that is what is abnormal. Because there are plenty of people with chronic pain that don't do that. You know, there are plenty of people that don't like freak out and throw like Kleenex boxes across the hospital room and, you know, pull like, you know, towel things off the wall when they're pissed when they don't get something and cuss everybody out. And you just point out to them that these are behaviors that are really not within the realm of normal, even if you have horrible pain. Because we have other people we can point to that don't have any of those behaviors at all. You know what happens to them in the hospital? They unfortunately, inadvertently get ignored. Because these other people are taking up everybody's time. Everybody's time. And one of the biggest pieces of difference between alcohol and opioids is that there's no leverage for an alcoholic patient in a hospital because we don't give alcohol for medicine anymore. So there's no arguing point. It's like, it's not like I'm going to ask for alcohol and they're going to give it. So the biggest argument you're going to get, unless you're like in some, well, that's a whole other caveat. But the only argument you're going to have is around benzos. I mean, and they'll still argue about benzos. And they'll call you a bitch, and they'll say it loud and proud. And, you know, I had mine who had Ozzy Osbourne tattooed to his hands. And every time he'd get angry at me, he'd tell me to F off and be like, Ozzy Osbourne. And I actually miss him when I moved. But at the same time, I would wake up in like cold sweats, like, oh, Ozzy, Jesus. Every time I hear it, it's like activating my old trauma, you know, from that. So the thing with these patients is once you just recognize that the behavior is the disease, then we're going to treat the disease. The frustration comes in when, 1, you don't recognize the behavior as a symptom, and 2, you don't know what the heck to do with it. When you're just like, I'm just not going to give them opioids, and you as the nurse are stuck because the doc leaves and doesn't have a conversation with the patient, just tells you that they're not going to give opioids. That's like inappropriate at 100 different levels. And so we have to start owning this as a group of people, and that includes administrators and nurses and front desk people and social workers to have an appropriate response to these patients. And the appropriate response for that patient is for the physician or the PA or the nurse practitioner, but usually the official, because they'll split everybody until they get like the heads of whatever. So you get basically the social worker and the physician and the nurse, and then you all go in the room and you sit down for 10 minutes. And they're all in the room, there's no splitting, you have the conversation, it's done in an empathetic way, and they're going to be happy or not happy, but the minute that you become consistent is the minute that behavior goes away. If my wife does something different than I do for my 6-year-old, you can bet he's going to pick which one did the thing he liked the best, right? And if I'm like in good dad mode, where I'm like, I feel guilty because I've been out of town so much, and I'm like going to be home, we're going to go in the back, and we're going to run around until I almost vomit, but you can keep going for 4 more hours, and like all of these things, he's going to come to me because he's going to know that he's going to get what he wants, which is that, you know, running around in circles. And he's going to know at the end of that I got nothing left in the tank, and he's going to be like, Dad, can I watch a show? He's not going to go ask my wife, can he watch a show? Because she's going to be like, no, you got to read 2 books before you watch a show, which is the appropriate parental response. But I'm like, whatever, dude, just Ninjago, awesome. And so as we look at this, that's the same way for these patients. And what they're going to do is they're going to come in and they're going to actually ask for a specific doctor in the emergency department. So I worked in Greenville. That was one of my first places that I worked when I moved here. I don't know how many people know Greenville up north of Grand Rapids. At the time, the emergency department had 7 beds, and we had just taken over the contract, the company that I worked for, and so I went up there, and, you know, in my mind, I lived downtown Philadelphia, so this was literally the middle of nowhere. Like, so dark, it scared me, you know. Like, I didn't need a pistol in Philly, but out here, I'm like, I need something. And something's not right, so of course I overdid it, and I have like, you know, an ankle pistol on the side, and call my buddies back in DC. Can you ship me my MP5? Because I'm a little, like, something's weird out here. I don't know. But we're up there, and I'm in this emergency department, and all I'm seeing are people that are asking for drugs. They're just asking for benzos or opioids. That's it, just over and over and over again. And every now and then we'll get somebody who wrecked their quad and they're all broken up, and I'll have some fun for a minute, and then we'd ship them off. But other than that, it was just like that. And I said, no, I'm not doing it. Now, I did it in an improper way, and I told the group that I talked to this morning, I kind of laughed. I go, when I first started this, I was really, really bad at having that conversation. I was always the doctor who didn't give the opioids to the people who were, quote, those people. That's back when I used air quotes for a living. And but when we did that, I did it in such a way that was not empathetic. It was like the first voice, right? When I was like, I'm not giving that to you. Don't be such a drug seeker, dude. I'm not giving you dope. I'm not going to give you dope. Stop asking. We're done. We're done. Bye-bye. 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 I mean, it was just like over and over again. And we would do that, and all of a sudden, my night shifts were awesome. They saw my truck, my silver FJ Cruiser sitting in the front of that thing, and they're like, that guy's here. Nobody showed up. I got like 6 hours of sleep. It was awesome. But I brought my wife's car one night, and it's the same as one of the other doctor's cars, right? It's a Subaru Outback. So I pull up, and I leave that in there. All of a sudden, there's like 30 people waiting to register, literally. All between the ages of like 20 and 32, all with chronic pain. And then they saw it was me, and then all of a sudden I saw like 2 or 3 of them, and then I think they had like a phone tree, and they're like, no, dude, call it off, code red. And then they just didn't show up anymore. But this is a real phenomenon. How many people know a doctor or prescriber in your community who overprescribes? How many of you have sent in an official complaint to the Licensing and Regulatory Authority of Michigan? Great. That's more than most. Every other person should send it in. They are mandated by law to evaluate that. Mandated to evaluate the prescribing habits of that physician. That is their job. They want to do it. Mike Zimmer wants to do this. So I am currently under a LARA investigation, which is super funny, for a patient I hadn't seen for 2 years because they were angry because I put a note in that said that they shouldn't have opioids because they have an opioid use disorder. And they put in a complaint that said that that was not appropriate use of opioids. And then so I'm now officially in the pathway for not writing opioids, which shows you how much they have to actually do an investigation. Now, they don't have to go through with it, all the way. They have to actually look at records and do those things as they should. But that's it. A patient called, and they started an investigation. I saw that as a success. A little bit of an irritation since I've moved, but at the same time, I see that as a success of the system, that a patient felt like something was wrong. They called the Licensing Regulatory Authority, and they followed through on an investigation. It's great. So I think that you have the power to actually change these actions. Because what I find is that those people who are delivering this don't necessarily mean harm. Most of the time they don't. They're just stuck in a situation they don't know how to get out of, and they don't have the backup and the education and the help to actually undo this large cadre of patients that they now have on stimulants, benzos, and opioids. There are some that are criminals, and they need to have their DEA license removed and not be able to be a doctor anymore. They've broken the oath, both from a philosophical standpoint and a legal standpoint. But there are others that just need help, because nobody else to take care of these patients. They all kind of ended up in this one place, and they end up writing for a whole lot of stuff, and they don't know what to do. They just need help. So figuring out the difference between those two is the pathway that we need to go. Yes?
Close to lunch, so maybe you can address this after. What about people, very rarely are we dealing with people with only an opioid addiction. So when they have maybe an amphetamine abuse issue, does that change your protocol with regard to recommending the medicine, or do you look at it as, let's eliminate this so we can address that? The question I ask is, one of the things that we come under fire for is when we make a referral to a doctor, we put them on Suboxone, for instance, they go to a doctor and they don't show up because the other issues have created the chaos.
Right. So the question is basically, do you do the same thing if somebody is a polysubstance abuser? And my answer is, we're going to have to talk about that after lunch because it's a deep dive answer, and I have yet to find somebody who only uses opioids. I mean, there's either always nicotine and marijuana and stimulants and benzos. I mean, it is a polypharmacy world, and so every addiction you're treating really is a polypharmacy addiction. So I'll absolutely deep dive into some of the realities of smoking and non-smoking and what these mean for even nicotine use for that when we come back. And then the goal for the second half is going to really dig into the specific things that you guys can do here to start implementing some of these pathways moving forward pretty aggressively. So thank you, and we'll eat some lunch and come back. Thanks.